Our first speaker is Andre Diavia, who's going to deal with comprehensive mapping of the LV summit, understanding the anatomy.
Thank you, Bill. The anatomy, one thing is interesting. A few years ago, we knew nothing about LV summit, and we are only ablated the RVOT. Over several years, then there is a completely different understanding of this region in terms of LV summit, CSVT, RVOT VTs, and aortic-related VTs. So the anatomy here, it's interesting, and I'm going to cover few aspects of this problem because others will talk more about the different approaches. This is what we would call the summit region, which is an area that is surrounded by aortic cusp, left atrial appendage, we'll talk more about it, the CS, RVOT, and then it is an area that is full of vessels and also full of fat. It's also important to keep in mind that this region, this very superior portion of the septum, because of the presence of veins and even arteries in this region here, we can treat intramural circuits using, as you will see, different approaches here. It's also important to note that because of the close vicinity, the close proximity of all these structures, sometimes the given target is as far or as close to many different of these anatomical structures. And for you to succeed, you have to ablate from different sites. So just theoretically, let's divide the LV summit in this accessible and inaccessible. I would call accessible when the target is close enough to your ablation catheter and you can burn. And you typically can get successful ablations using this kind of approaches. Inaccessible, in my mind, is when you cannot get too close to the target and get a successful ablation from one specific site. And that's why the site, let's assume that's equally far from all potential sites, and you will have to succeed, you have to ablate from different regions in the same patient. That's why this is a situation where we should consider not only ablating from your best site, but also from your second and even your third best site, because this is the only way for you to surround, let's put it this way, the inaccessible LV summit. Whatever you want to do, I think you need to follow a sequence. You can start whatever you want, but before ablating with unipolar, bipolar, half saline, vessel, everything, you need to follow a sequence of mapping. You should always consider placing a catheter in the CS, and if possible, if you can have this catheter here inside the anterior interventricular vein, then map the cusps, map the RV, and be sure that when you map the RV, you keep below the pulmonic valve plane, because burning on top of that can actually cause some coronary injuries there. And one thing that we should also consider is mapping the left atrial appendage, which typically points to that region, and also the septal veins that Fermin is going to talk to you in a few moments. Back in 2006, we described some distal CS PVCs and VTs, and as you can see here, when you look at the electrogram, the electrocardiogram, most of them do have tall R in V1, but in one of these patients here, this is like, I would say, like a potentially a typical LV summit electrocardiogram. There's some details there, but this is what you typically see coming from that region. As I was mentioning before during the live case presentation, I think that when you have a CS catheter and you are able to bracket the ventricular activation inside the coronary sinus, this suggests that you are in an area that is good for ablation. Please note that what we are recording here with this nice ventricular electrogram is also related to a very tall A, suggesting that we are very close to the left atrial appendage when mapping that distal inside the coronary sinus. And as we start ablating there, very quickly the PVC disappeared. We came up with these suggestions that when you have bracketing inside the coronary sinus, we should again follow a few steps. it's important for you to make sure that you're able to map the entire extension of the coronary sinus, the anterior intraventricular vein. Many of these patients, you will have to shoot an angiogram to know the anatomy. Bracketing the activation there is very important. Typically, uni is okay, but you almost always see a small R wave, like in the previous presentation here during the live case, and that's why the pace map is rarely 12-12 match. There is always a notch or another one that is not perfectly fine, but despite of that, as you ablate in that region, you can eliminate PVCs related to this very distal CS. Sometimes, and I'll talk about that in a minute, you have to use freeze saline. This is an example. It's a paper published by a friend of mine in Brazil, and he was not able to deliver enough power to the distal CS because he was using regular saline. There are other ways for you to deal with the situation, such as half saline, but one other option is to use cold saline, and when you do that, you're going to be able to deliver a lot more power, and in this particular situation, it was necessary to get rid of the PVC. I had the same experience. In a few patients where I had to use cold saline during the distal CS ablation. The problem when you're delivering there is that this is one of the regions where you have to be aware and careful with the potential damage of the coronary arteries. Not only the LAD, as Srini was showing, the catheter was pretty close to the coronary arteries in the diagonal, but also, depending on where you're burning, you have to consider that there is a small distance between the coronary sinus and the circumflex artery. As you can see here, in the very anterior portion of the mitral annulus, the distance can be as small as 1 millimeter. So you need to take this into account and be aware of the potential side effects of this ablation. This is an old case, but it's a beautiful case. This patient, we decided to map this tachycardia, this ventricular tachycardia, along the mitral annulus because of the morphology was very suggestive of a left lateral accessory pathway. And as you can see here, once the catheter got inside the left atrial appendage, we were able to record this beautiful electrogram here, and using this electrogram to guide our ablation, we are able to stop this tachycardia. As you can see, depending on the anatomical location of the left atrial appendage, especially if you go inside and you counterclock, you might be able to cover a fair amount of the LV summit. So this is one of the options that you have if you're struggling with PVCs or VTs coming from this region here. This is a recent publication by Tang's group showing that that's exactly what they were able to do. They were able to find, using a robotic approach, they were able to find a ventricular foci very close to the left atrial appendage. So again, it's not something that you're going to do all the time, but depending on the electrograms that you can get from that region, this could be an interesting approach. And I'll tell you, the LV summit, it's a kind of ablation that is full of tricks. This is just one of them. Which is interesting is also to know that because of the presence of fat in this region here, epicardial approach is not as useful as you would like in this particular situation. This is the presentation from the Penn group, and very few patients had a successful epicardial ablation when the PVC was coming from this region there. And what I find that is really interesting in this situation, and this is going back to my first slide, is that sometimes, because of you're not able to reach a potential target that is in between all these points here, and you have no access to veins, for instance, one option that you may have, you just have to burn from all three best sites that you have around the LV summit, like RVOT, distal CS, and even endocardial ablation. Which is interesting is that in many of these patients, and I have had the same experience myself, sometimes you will see late resolution of the problem. So it's a failure procedure. When you bring the patient back and you ask for a Holter, you realize that the patient is not having more PVC, even though the patient left the lab having by Gemini. I have had this experience myself a couple of times. So to summarize the talk, I think we need, for this kind of VT and PVCs, go for a systematic mapping approach. CS catheter always helps. And LV, left atrial appendage ablation, is doable, but it's risky, so you need to be careful with that. And should always consider ablation from the second and third best side if you cannot get it from your best location. And be aware that late results are actually possible in this kind of situation here. There is a sequence of ablation strategies that one can use, and I think they will discuss these different approaches during the session. Thank you.